What's up, everybody? It's your girl Meagan, and today I'm going to be going over my third ACL surgery, what happened, the anatomy behind it, and a little recap at the end, the day of surgery. Now, for those of you guys that are tuning in for your first time, I am our director of CPTs, instructor, and trainer here at Show Up Fitness, where I got my knowledge and background with anatomy, and I am an athlete. That's how I got injured playing soccer for the Dominican national team. Now, this was my third ACL surgery. Second on my left leg. So with that being said, with my other two surgeries, I didn't really document it as well. So this third time around, I want to make sure I provided as much information for those of you out there that you're either currently going through the process, going to be going through the process, know somebody that is, or just want to know more about the knee, about ACL injuries, because it is a very common injury nowadays. And so with that being said, if you guys have any questions or want to see specific types of videos, go ahead and comment below. And if you haven't already, go ahead and follow me on TikTok. I do have a lot more videos on there about the day-to-day activities going through this recovery process. And of course, if you haven't already, make sure to subscribe so you don't miss out to any of my new content that I have to make. Now, I'm going to go over knee anatomy, just the basics of it, not too much in depth, hopefully, but just to give you guys some background of how the ACL is injured and whatnot. And so the knee joint is going to be a hinge joint, and it's going to compromise three bones here. So we've got the leg bone, the big guy, the thigh bone or femur, the kneecap, smaller bone, it's going to be your patella, and then this bigger bone of the lower body, the tibia, referred to as your shin bone. These three bones make up the knee joint in general. And of course, breaking down the knee joint, you also have two other smaller joints that compromise the knee joint. So you have the patellofemoral joint, your patella to your femur, and then you have the tibiofemoral joint, your tibia and your femur. So those joints are going to help make your knee move, right? And so the hinge joint, just the knee joint overall, is a synovial joint. And this joint is going to have synovial fluid capsules, which allow for more lubrication, which allows for this joint to be more mobile, which is great, but it's also why more prone to injuries and wear and tear down the road. So let's get a little bit more into it. So there's four ligaments that we're going to be looking at that help stabilize this knee joint. And so you're going to have an ACL, PCL, MCL, and LCL. So ACL is your anterior cruciate ligament. PCL is your posterior cruciate ligament. So cruciate meaning crossing one another, anterior, front side, posterior, back side, ligaments, tissues that connect bone to bone. So my anterior cruciate ligament is going to go from, you guys can see here, it's going to go from the lateral, but the medial part of my lateral condyle on the femur, going down to the tibia here. My PCL, posterior ligament, is going to go from my femur down to the back side of the tibia. So those two make an X, which you guys can see a better description on that picture over there, but they cross one another. And their purpose is going to help with, once again, stabilizing the knee, making sure that forward and backward movement from the tibia and the femur. You have your LCL and your MCL. So your LCL, lateral collateral ligament, and your MCL, medial collateral ligament. Those ones are going to be on the sides. So lateral collateral ligament is going to go from your femur to your fibula, this small bone on the outside, and then your medial collateral ligament is going to go from your femur to your tibia on the inside. This is the right leg, so I'm showing you guys inside of the knee, outside of the knee there. And so these four ligaments help stabilize this knee. The main one that we're going to be focusing on today is going to be the ACL, because that's what was torn with me. And so your anterior cruciate ligament is going to help specifically with that movement back and forth from your tibia and your femur. So because I tore my ACL, now my tibia could go in front of my femur, which is what happens when you get that lockout or you get a sudden instability when you're walking and you feel like you just can't hold yourself up, because that is no longer there. It also helps with stability with any rotation and stuff. And usually what happens is because this one gets injury with a quick twisting movement, contact, non-contact. Now for this third injury that I have was a lot different than my first two. The other two, the first one that I did on my right leg, I only tore my ACL completely. That was it. And so that one was a pretty smooth process. My second one, I tore my ACL, slight minor tear to my MCL, but still nothing crazy. And then this one, what had happened is I tore my ACL, I tore my medial meniscus, as well as getting exposed bone. And so this is what had happened. Not sure if the second surgery that I had on my left leg, if I had a small tear in my meniscus and it just wasn't caught or it wasn't noticeable, or if I just had torn my meniscus throughout that time and didn't realize it, and just got slowly worse and worse. So I tore my meniscus, which ended up only about 60% left of my meniscus now, but because of that tear in my meniscus, led to degrading of that articular cartilage on my femur, so exposed bone. So within this joint, you're going to have articular cartilage. That's cartilage tissues that are going to surround the end of the bones here, so the condyles. So we have medial inside and lateral outside condyles of the femur. You're also going to see articular cartilage underneath the patella as well on the tibia there. So those articular cartilage are smooth and helps with the gliding of bones past one another. Now, in between the femur and the tibia is where my meniscus is. So you have lateral meniscus on the outside and medial meniscus on the inside, kind of two little loops there. And they are thicker than the other types of cartilage. And because of that, they act as a shock absorber. So when I ended up tearing my meniscus on my medial side, that allowed a lot more stress onto my articular cartilage on the medial side of my femur. And so that's why the breakdown occurred. And that's why what had happened is I had a big piece of here of exposed bone. And so for this third time around, not only did I have to get a new ACL, I also had to get a bone plug for that femur. Also to note, because the surgery was the second time on my left leg, before this other surgery even happened, I had a prior surgery in November, a couple months ago, doing bone grafting. So they fixed the tunnels that my other ACL that was repaired were in, and then removed all of the floating pieces of cartilage, loose bodies in my knee, and just touched up anything else. So then a couple of weeks ago, the surgery that I got was going to be an allograft for my ACL, an MFC, osteochondral allograft, bone plug, and then lateral external tenodesis. So that's a lot of things that happen. So this surgery is a lot more severe, which is why my protocol is a lot different than my first two, why I'm still on crutches, why I'm in a brace. Now for my first ACL surgery on my left leg, I ended up getting a quad tendon. So autograft from my own tissue. Now the tendon is going to connect muscles to bone. So with that, they took a piece of my patella as well as some of the tissue connecting to my quad. So with that being said, this go around, I wanted to use my patella tendon because that's what I've done on my first ACL surgery on my right leg, and it's been great ever since. But if I were to do that and grab that piece from that side, I'd be at a higher risk for fracturing my patella. So definitely didn't want that. So we went with the option with allograft. Now an allograft is a cadaver tissue, a donor tissue. So thank you to all the donors out there that make surgeries like this possible. Otherwise, I would not have been able to do this. They had replaced my ACL with a cadaver tissue. And then the MFC, osteochondral allograft that I was talking about. So that exposed bone on my femur, medial femoral condyle, they got a piece of, once again, a cadaver tissue that was donated, but it's a piece of bone and cartilage that's on there. So they stuck that into my bone. That's why it's a fancy thing of saying bone plug. On top of fixing my medial meniscus, so just scraping it up, whatever else was left. And then because this was a revision surgery, because I do want to go back into playing soccer and high-level activities, to be extra safe, especially because it is an allograft, not my own tissue, and second time going around, also did a lateral external tenodesis. And so what that is they had to grab a piece of my IT band. So your IT band is going to be fascia on the outside of your thigh. And so they grabbed a strip from that. And what they did is they placed it underneath behind my LCL. And so your LCL, like I said, is going to go from your femur to your fibula there. And so where they placed that extra piece was going to be from my femur to my tibia on the front there. So that's going to add for extra support to try and help prevent any rotation and trying to preserve and just really help the success rate of this graft, because I'm more likely with an allograft revision surgery to tear my graft. So trying to do everything possible to make sure I don't do it again. So that was kind of longer than I thought, but just a breakdown of the knee anatomy and everything goes into it. And so that's why I said like this go around is a whole lot different from my past surgeries and may even be different for your guys's. But I just want to share what I'm going through in case there is someone out there that's going through the same thing, or just in general, the process in general, recovering from an ACL. You really don't know what it's like until you're going through it. I wish that no one else would get it, but it's very common. And so, with that being said, the insight behind it, I just want to let those of you guys know that are watching it that you can get through this. You will get through this. Have a positive mindset. Find the little things throughout the process that make you happy. Celebrate the little moments where you get to finally walk, where you get to bend your knee a little bit extra, where you get to start riding the bike, because it is a hard process, not only physically, but mentally and emotionally. So with that being said too, don't ever compare your ACL recovery to someone else's recovery. Everything is different. Everyone will move at different points. Don't feel like you have to be at a certain point where I'm at, where you're at. Do what you can, push yourself within the limits. Ask your PTs and doctors what's safe, of course, but I'm telling you that you can do this and you will do this with that positive mindset and attitude. And so going into that, I've said it on another video before, but the best thing you can do for this surgery is really attack the rehab, but most importantly, the prehab before surgery. So as soon as you guys find out, hey, I tore my ACL or my MCL, my PCL, whatever you tore in your knee, if you tore it and you find that out, attack the prehab, get with a physical therapist and start that process. Because once you have surgery, it's going to be so much harder if you didn't do the work behind it. So you want to create a strong foundation. We're able to gain that range of motion back, full extension. Quad strength is very vital in this one, especially depending on the grafts that you choose. But you want to do as much as possible before that surgery, because as soon as surgery happens, as you guys maybe have seen in my other videos, there's a whole lot of atrophy that occurs, and it's a lot harder if you didn't put that work in beforehand. And I didn't mention this before, but ligaments, like I did say, bone to bone, they are avascular, meaning that they have little or lack of blood supply, which is why this recovery takes so much longer than other injuries. And so really pay attention to what your doctors say and your PTs provide you, because you don't want to mess up, especially on the early stages of this, and put yourself at a higher risk of injuring or re-injuring this injury. It takes time. You have to be patient with this entire process. So with that being said, next, I'm just going to show you guys a couple clips, videos, pictures of the surgery day of what happened to me, getting back home, expectations, all of that. So continue watching if you'd like to see that. I checked in the hospital at 6:15 in order to fill out all the paperwork. And around 6:38, they took me upstairs where I changed into these scrubs to make sure everything was sanitary for the procedure. They then checked my vitals, and I wrote on my leg as well as my doctor to ensure the proper leg was being worked on. And then I headed into surgery around 7:30 a.m., probably being worked around 8, coming out at 11:30. As you guys might be able to see, I was shaking and clearly still loopy from the pain meds. They also gave me a heater underneath the blanket to keep me warm, try and stop me from shaking. And then about 20 minutes or so, once they thought I was ready to leave, they wheeled me out in a wheelchair, and then my sister picked me up. So I cannot put any pressure on this leg, so they had to help me in and out of the car. I sat in the back so then my leg could be rested the entire time. And then when I got home, used the crutches to get back inside the house. And as you guys can see, it was a long day, so I knocked out. Now don't forget to like, comment, share, and subscribe. And as always, thanks for watching.